Good afternoon to one and all present here and to all the viewers who have joined us virtually. The first speaker of today's scientific symposium is Dr. Prithvi Balepur. Dr. Prithvi Balepur is an accomplished oral and maxillofacial surgeon, an head and neck oncosurgeon, and an oral implantologist who is currently working as a consultant in Shankara Cancer Foundation. Dr. Prithvi did his bachelor's degree from A.B. Shetty Memorial Institute of Dental Sciences and completed his maxillofacial surgery in Savita Dental College in the year 2008. He went on to work in Kidwai Hospital for 4 years and completed fellowship in oral oncology in Kidwai Institute of Oncology. He is an associate fellow of American Academy of Implantology. He has completed his membership in Royal College of Surgeons. Along with many hats that Dr. Prithvi dons, he is also an accomplished sitar player and an orator par excellence. May I now have the privilege of having Dr. Prithvi to share his experience on the initial management of mucormycosis.
Thank you, Swaroop. Good afternoon, one and all. At the outset, I deem it my privilege to extend a warm welcome to all the participants and delegates to celebrate the International Oral Maxillofacial Surgeons Day along with us on February 13th. As a part of the association office, I deem it my privilege to give you some insights about how mucormycosis has ravaged our country, our population, our society in the last 1 year. When the whole world was going through pandemic with Delta variant affecting the continents after continents, India was not spared. In addition to the pandemic, India faced a very disastrous infection, a fungal infection, a rare fungal infection of sorts called as mucormycosis, which completely debilitated our patients, mutilated them, and scarred them for life. And when we started seeing these patients in our emergency rooms, we were wondering what exactly was this kind of a situation, which I had not seen in my life with my almost 15 years of experience in maxillofacial surgery. And believe me, all these patients were so sick, they were toxic, and they all died helplessly, and we were also helpless, unable to help them in their hour of need. As you're all aware, mucormycosis is caused by thin, fragile, filamentous fungi called as Mucor of order called as Mucorales. And we all know that these fungi grow on putrefying organic matter in the environment. The spores of which are all there, and I'm inhaling it, you're all inhaling it. So long as our immune system is hale and hearty, nothing is going to happen to us. It's only in these, it's only in patients who are predisposed, who have predisposed conditions like diabetes mellitus with or without ketoacidosis, hematological malignancies, solid organ transplantations, prolonged neutropenia, iron overload, AIDS patients, severe patients, they're all immunologically debilitated, and they're the ones who are at a high risk of developing mucormycosis. In our subcontinent, the bulk of mucormycosis we saw in uncontrolled diabetic patients. And just to highlight the point that there is putrefying organic matter everywhere in the environment, I just posted this photo of a mango which was rotting, and the spores are there for us to inhale, but nothing happens to us. It's only in these predisposing factors, the patients suffering from them are affected with mucormycosis. There was a status report from of India from ICMR, which suggested that there were more than 45,000 Mucor cases across the country as on September 2021. And ICMR studies revealed that there were about 3,228 Mucor deaths. And we have seen in our practice cases as young as 10 years to about 84 years. We have seen a whole gamut of mucormycosis patients affecting these age groups. And mucormycosis was simultaneously seen in COVID positive patients in about 32%. And the rest of the Mucor cases were seen in COVID patients who were convalescing from their disease process in about 4 to 6 weeks of time. And 80% of these infections were pathologically proven as Mucor. The rest were aspergillosis and candidiasis. And the interesting thing was, in our experience, in our workplace, we saw about 90% of these patients were not vaccinated. And this really highlights the importance of vaccination. Even if the patient is a diabetic patient who was suffering from Delta variant, if he was vaccinated, the intensity of the infection process and the mucormycosis would have been less. So there were a lot of hypotheses which was proposed at that time. And some hypotheses are now turns out to be true. especially the Delta strain, which was prevalent across the globe, and it is said to be immunosuppressive. So imagine a Delta variant in an individual who is uncontrolled diabetic. Uncontrolled diabetics are always immunocompromised. On top of that, they take injudicious steroids to help their lung functions. At the same time, the steroids have their own immunological debility. At the same time, they were doing all unscientific, unreasonable practices like steam inhalation, eucalyptus oil inhalation. All these were detrimental to the nasal mucosal functions, and which would have otherwise fought with the spores of mucor. And injudicious consumption of antibiotics, all this led to overall suppression of the immune status of the patients, and overall, at the end of which, they all suffered with mucormycosis. If you look at the pathophysiology, I just roll through. It's because of uncontrolled diabetes, you have a low pH in the system, which is facilitating the easy germination of all the spores once the patient inhales. And there is decreased ability of transferring to chelate ion. That's first point. Secondly, there is glycosylation of transferrin ferritin. Obviously, there is increased iron load. And mind you, Mucor thrives on iron load. And in cytokine storm, there is increased ferritin level. That's why we see for ferritin levels. So all this was conducive for the growth of Mucor, especially in a patient who was uncontrolled diabetic, was suffering from Delta variant, was immunosuppressive, had consumed steroids, and what ensued was a mayhem of sorts. If you look at the cross section of a blood vessel, you can easily make out that there is mechanical angio-invasion of Mucor fibers into the Mucor, the hyphae into the lumen of the blood vessels. And we all knew that COVID was also causing, Delta variant was also causing thromboembolism. So there was a double whammy of sorts. You have thromboembolism due to COVID. At the same time, you have mechanical angio-invasion of Mucor hyphae into the intima of the blood vessels. All was causing avascular necrosis of the of the organs which these blood vessels were supplying. And since the bulk of Mucor cases were seen in the head and neck area, and the organ which was easily affected was the organ which was first targeted was the maxilla. And if you can classify mucormycosis, you can segregate them into rhino-orbital mucormycosis, which was the bulk of Mucor cases which we saw. We also saw pulmonary mucormycosis, GIT mucormycosis, cutaneous mucormycosis. It was also affecting kidney, heart, and nowadays there are papers from the Orthopedic Society saying that there is avascular necrosis of long bones, all attributed to the Mucor. And this is one slide of Mucor affecting the pleura. Now, clinical presentations, I would like to draw your attention here, as most of them are dentists and maxillofacial surgeons. Patients do complain with facial swelling, numbness, stuffy nose. If the patient comes to you with loose set of teeth, with sinus openings, with pus discharge, and the patient says in his history that these teeth were all fine in about 20 days' time, and in these last 20 days' time, the teeth have become very mobile. These are the situations which you have to think about Mucor, and you should not jump the gun and start doing your dental treatment, because we're in the middle of pandemic and Mucor is endemic. So you should always have a cross-referral, ascertain that it is Mucor or not Mucor, and then get along with your either dental procedures or your other procedures to treat mucormycosis. The diagnosis part I will not go. And it was when we were operating at Bowring Hospital along with my colleague Dr. Hemlata, we had tough time, especially diagnosing the cases, because fungal specimens were taking 6 days to almost 8 days to prove. By then, the disease was increasing in size and width. So we were relying upon the potassium hydroxide staining, and the broad aseptate branching hyphae was pathognomic of Mucor. And we did our own small study about pathways of spread of mucormycosis. This is a normal PNS view of an individual who has got clear sinuses and is a healthy individual. And as I told you, imagine this patient to be a Delta infected patient who is uncontrolled diabetic and who is on all kinds of steroids and antibiotics, and is inhaling the spores of Mucor. The Mucor spores just goes in, it's an easy passage to the nasal cavities and gets consolidated into the sinuses. And as I told you, the first organ to be hit there because of the proximity is maxilla. And at this juncture, the patients used to have the dental issues, loose teeth, pus discharge, sinus openings, and then if it was left untreated, it would ascend up and cause infections into the orbit, ethmoids, sphenoids, and the skull base. This is the resected specimen of maxilla. In the slide, you can see there is dehiscence of the palatal mucosa. But when you look at the video, there is a necrotic nasal septum which is infested by Mucor. And when I flip the specimen, there is exactly dehiscence of palatal mucosa at that point. This itself proves a point that there was mechanical angio-invasion of Mucor into the perforators of supplying the nasal septum, and subsequently what you saw was dehiscence of the palatal mucosa. And this was a patient who said that all his teeth was fine for almost 20 to 30 days, and in the span of 20, 30 days, they've all become mobile. So again, I'm warning all the dentists here and maxillofacial surgeons, you are in the pandemic where, excuse me, Mucor is endemic. So when you see this kind of situation with the classical history of patients saying a COVID infection patient with diabetes and consumption of steroids with losing of teeth in the sudden onset, you should be very careful not to jump the gun and start your dental treatment. These are not the cases for dental treatment. Again, these were the presentations which we saw. The patient comes to us with multiple sinus openings. When you palpate, the whole maxilla is shaking away from the cranial base with multiple sinus openings. So these are all pathognomic of Mucor, and they are not dental infections. And when you take our standard orthopantomogram, you see excessive destruction. Again, one might get confused to this to be a dental infection and start the treatment accordingly. And these were the various palatal presentation of Mucor patients. They could be engorged palatal mucosa, there is excoriation, they can be complete bulged palatal mucosa, infected palatal mucosa, and if it increases, you have complete sequestra forming in the alveolus or in the palate. So these were all the presentations which we saw in our practice. And there was complete necrosis of palate in advanced case of mucormycosis which were not treated. Furthermore, there were sponged out lesions in the lateral skull, and these were all had a lot of mortality, especially in these class of patients. Who says Mucor doesn't affect the pediatric class? This is a 13-year-old girl who is a juvenile diabetic. Her parents had COVID, so she contracted COVID and complete involvement of the left side of the face. Unfortunately, she had to lose her eye, the palate, and she was very sick, and somehow she survived the onslaught. So basically, the treatment plan for mucormycosis is surgical debridement, and only surgical debridement with or without antifungal therapy. And it involves multidisciplinary approach, wherein otolaryngologists, oculoplastic surgeons, neurosurgeons, and we as maxillofacial surgeons come together along with a good endocrinologist to control the glycemic control, and our support from microbiology and pathology to help these patients get over the problems. And I would like to share a few slides about how Mucor was behaving, especially when we were examining the resected specimens. This is a 28-year-old gentleman without any history. He turned out to be diabetic post-COVID. And look at the way he unfortunately had to forego his entire maxilla. Look at the way the Mucor has infested both the sinuses. Look at the amount of dehiscence of the buccal bone. If you look at his video, as dentists, we wouldn't have seen this kind of bone loss anywhere in our career. There is complete dehiscence of bone from one molar to another molar. All the teeth are mobile. How could you help this 28-year-old gentleman with this kind of a Mucor affecting his entire jaw? He's scarred for life. Again, if you look at the CT scan, there is a Mucor-infested sinus on the right side. But if you look at the specimen, I've resected the left side, hemimaxilla. This was because by the time we took this case to OT, it was about 8 to 10 days post-diagnosis. By that time, the tumor had, the disease had progressed so much so that he had to lose his left side hemimaxilla, and the otolaryngologist had to somehow salvage the right side by doing a functional endoscopic sinus surgeries. This is the extensive case of rhino-orbital cerebral mucormycosis, which we shouldn't have attempted, but then we attempted it and burnt our hands miserably. This patient had complete involvement of the entire right side of the face up to the skull base. He also had a CSF leak. And then with support from the other specialties, we operated on this case. We did bilateral maxillectomy, rhinectomy, sphenodectomy, ethmoidectomy, orbital excenteration. Unfortunately, we lost the patient 4 days post-op. The same patient, if you look at the first picture, when I'm drilling into the maxilla, you don't see a spurter, you don't see a drop of blood. It was just drilling into a hard bone. That kind of necrosis we saw in the maxilla. And when you look at the video, just by digital pressure, I was separating the maxilla from the skull base. And the entire nasal cavity was infested with Mucor. So this was a kind of disastrous disease which engulfed our population in recent times. And this is a very rare case of mandibular mucor, which we did in Bowring about 3 cases. And if you can look at the CT scan, there is punched out lesions right from one subcondylar area to another subcondylar area and left side hemimaxilla. Imagine his plight. He's just 48 years old gentleman who's a school teacher. And as I told you, he had multiple sinus openings, mobile teeth, pus discharge. The same description holds here in a COVID patient. And look at the CT scan, there's punched out appearance everywhere. And this was a case, again, as I told you, when you look at his clinical scenario, the whole maxilla is shaking of the skull base. So is his mandible on the left side. We thought we'll save the right side mandible. But again, you can see the entire system, the entire stromatognathtic system is completely infested by mucor mycosis. How could anybody save any organ here? This was a dilemma for us, but still we took up this case. And this was the surgery which we did at Bowring Hospital. We gave a visor incision, raised the flap subplatysmally from one mastoid area to another mastoid area. Because these patients do require microvascular fibula graft at a later date. So we had to preserve the neck and the vessels for anastomosis at a later date. We had to resect only the infested part. So we spared the masseter muscle bilaterally so that it will act as some coverage for our reconstruction plates. And when I tilt the patient, you can see that there is complete punched out appearance, what you saw in the CT scan. You can see my instrument is going through and through into the mandible. That kind of destruction we had seen in these patients. For paucity of time, I'm just going to scroll fast. Again, after resecting the mandible, now we're left with maxilla. Okay, he has the lower portion of the mandible missing. Now he has got another dilemma, a dilemma for the surgeons also to resect or not to resect his left side maxilla. But then, as per the protocol, we had to operate. So we operated him, and that's how he is. So he's left with only right side hemimaxilla. Look at his plight. He's got a complete antigum deformity. He's been tracheostomized. For feeding purpose, he's got a percutaneous endoscopic gastrostomy, and he's awaiting for a microvascular fibula graft. And it's a long wait. So this is the kind of situations pan-India, all my colleagues have witnessed in their centers, and that's how we achieved his intraoral closure and the extraoral closure. We gave 2-layer closure, supporting some reconstruction plates just for the sake of just to buy some time. And then we've sutured all the muscles to the reconstruction plate and then closed the flaps. And if you look at the specimen, you'll be aghast. It was completely necrosed mandible with a sagittal split. And as you saw in the maxilla, there was complete dehiscence of the buccal bone. There was nothing left for us to salvage in this case. So we were forced to resect from one condyle to another condyle. And if you look at this video, you can see the entire marrow infested by mucor. So this was the situation which we were faced. And this kind of mandible mucor mycosis is far more morbid. I somehow feel maxilla is better off. And this is the specimen. The patient has lost his face. Now, as guardians of face, maxillofacial, who else would be interested in maxilla and mandible? It is we who are interested in maxilla and mandible. And that's how some other patient who has lost a mandible from angle to angle looks. He's got a plate which is protruding out. Anytime that can show through the skin, or anytime it can show through the intraoral mucosa. Just to buy time, we have given this kind of a closure for this gentleman, and he's awaiting microvascular free fibula graft in near future. And for maxillectomy defects, this is what we are seeing. These are the patients who are reporting to our OPDs with this kind of defect, either hemimaxillectomy defect, bilateral maxillectomy defect. And with great difficulty, the prosthodontic chapter has literally contributed, has done yeoman service at Bowring Hospital. About 90+ patients have been rehabilitated by obturators, but that is only a stopgap arrangement. Going further, the association literally wants to garner more support and funds for giving them permanent prosthesis in the form of patient-specific implants or zygomatic implants, because we are the ones we are interested to reconstruct and rehabilitate them. And again, if they are medically fit, we would like to give them the option of microvascular free fibula graft. So these are the options which we have, and we have envisaged as the association. So friends, to conclude, mucormycosis has completely ravaged our country. The impact of it, only the surgeons who have operated know. And literally, this has caused issues as far as chewing is concerned, swallowing is concerned, speaking is concerned, and many have got have ended up in depressions and suicidal tendencies. As I told you, the normal way of treating them and reconstructing them is by microvascular free fibrotic graft. That's the gold standard. Otherwise, if they're medically not fit, the patient-specific implants or zygomatic implants, for which the Association of Oral Maxillofacial Surgeons are literally garnering support. And please, we request each one to reach one, because everybody will have contacts. So we would like to help these patients. And our own survey says that there are more than 4,000 patients waiting for such kind of reconstructions, rehabilitations in our country. So with this, I conclude my talk. Thank you very much. And I would like to acknowledge the entire team of Bowring Hospital, the director, medical superintendent, the otolaryngology departments, Dr. Hemlata, my dear friend, Dr. Tejaswini, and then Dr. Anand for that, and the entire postgraduate students for that service which they have rendered to those unfortunate patients. Thank you.
I would now like to invite and introduce the next speaker for the scientific session, Dr. Deepak Haldipur. He is the alumnus of the prestigious Bangalore Medical College, an internationally renowned ENT surgeon who brings an immense experience spanning over 3 decades in the field of otolaryngology and head and neck surgery. He is one of the foremost ENT surgeons of India who has mastered excellence in skull-based surgeries, both endoscopic anterior and lateral skull base. He widens his immense knowledge as a mentor surgeon for cochlear implant programs in various institutions and hospitals. He is a strong proponent for implementing the state-of-art technology and innovation into practice and uses implementation of medical products to deliver highest level of care. Apart from his surgical skills, his most notable attribute stands out as his human approach to ability to treat patients with a smile. We now request Dr. Deepak to give his experience on mucormycosis and ENT perspective. Over to you, sir.
Before Dr. Deepak begins his talk, may I request Dr. Deepak to give away our token of appreciation to Dr. Prithvi Balepur. Thank you, sir. Over to Dr. Deepak.
After such an exhaustive talk by Prithvi, I have very little to say. Unlike Prithvi, who did a lot of service in Bowring Hospital, which was totally free, mine was more of, I was a commercial actor doing the blue-blooded private practice. And we had our share of Mucor cases during the pandemic. Before I start the talk, I have to acknowledge the efforts of Tulsi Naik and Dr. Aditya, who helped me with the slides. The properly recorded, or where we have the complete statistics to its logical ending, including the 17 people whom we lost, I think 37 people whom we lost, but 17%. We have documented about 202 cases so far. About 21 of them presented to us when they were actively COVID positive, some of them on oxygen, some of them on the BiPAP and all that. About 6 people had a history of COVID 1 week back, 53 of them 2 weeks back, another 53 3 weeks back, 29 4 weeks back, and about 18 which were beyond these cases. And about 8 people of Mukar did not have an official diagnosis of COVID. We assume because they came in the Delta wave itself, and a lot of them were not really diabetics also, found to be diabetic during the time. And one remarkable feature we saw was in many of these people, which you will see in the subsequent slides, their HbA1c was higher than their HP percentage. No? So this Delta virus was really, About steroid use, about 93% of them had taken steroids. About 5% had not taken steroids at all, not even a single tablet or injection. And another 2%, we didn't have the data. whether they're taken or not. As I talked to you about HbA1c, again, only 2 of them had less than 5.7, and other people it was 5.7 to 6.4. But if you notice, between 7.1 to 8, we had 23 patients, 8.1 to 9, we had 19 patients, 9.1 to 10, 35 patients, and 10.1 to 11, 31 patients, and 11.1 to 12, 25, 12.1 to 13 were 21, and more than 13 was 9. And as I said earlier, in majority of them, their hemoglobin was lower, the HbA1c was higher. The disease, nearly about half of them, the disease was in the ambit of paranasal sinuses, the orbit, and probably involving the walls of the sinuses. A fair number of them in the second half, the second 50%, had maxillary involvement, and some of them, fortunately very less, about 8 to 10%, less than 10%, had an intracranial involvement. The presenting complaint mainly was a typical facial pain, a severe facial pain the previous day, followed by a paresthesia along the same area next day morning. A lot of them came with facial swelling, visual disturbances, headache, the neuralgic pain, then pain in the eye, the infraorbital numbness, which was very common. A fair number of them came with epiphora, loose tooth, nasal discharge, and blocked nose. In fact, whenever the teeth were mobile, obviously the onus went on to the maxilla. The disease extension, pure sinus disease, we had about 36 people. Sinus disease with an extension going into the pterygopalatine fossa or the infratemporal fossa or retromaxillary extension, another 16 people. Sinus with the orbital wall involvement and going into the orbit, especially the medial aspect, it was another 57 people, which means roughly around 109 out of 202 could be managed endoscopically, and the remaining we had to use the help of the allied specialties. So the maxilla involvement or the alveolus and palate was 62, which is the largest number in this subgroup, you can see. Sinus and intraconal disease was about 21. Mandible involvement was fortunately less, only about 2 patients, and untreated were about 8. Obviously, the 109 of them underwent endoscopic debridement and sinus surgery. A lot of them underwent maxillectomy. A lot of them underwent orbital excenteration and the intracranial abscess evaluation. I think that was a few cases only, but remarkably, all of them did well. All the people with intracranial abscess formation did well. Medical management, initially to our good luck, we were well stocked with amphotericin, which is one of the reasons why we probably got a lot of numbers into our center. That was a main factor, and we could use it. In between, we went into a phase of 3 weeks when amphotericin is not available, and government took over the care of dispersing that. We had to transfer many of these patients to the government hospital. So we had to rely on posaconazole. When we look back, posaconazole didn't do very great. It was a so-so drug with, whereas isavuconazole or Cresemba, this was far more convincing and far more better drug. Amphotericin plain, if there were no toxicity effects, was also equally efficient and effective. So also the other variants, the lipoidal and all that. Of course, the gold standard was amphotericin, but because it was not available in between, we had to resort to posaconazole as well as isavuconazole. We lost about 37 patients, so we had about 18% morbidity. So compared to probably the routine non-COVID mucors that we saw, fortunately the morbidity or mortality was still less compared to whatever statistics we went through in the literature. Rehabilitation, both oral and ocular, taken care of exclusively by our MaxFax department. They are at it, we are on the job. And you can see some of those slides depicting that. Prithvi has been more explicit about that. You can see one of the first persons to have the orbital or ocular rehab. The smile on his face tells it all. What I want to emphasize before I finish my brief talk, for me, this was an amazing example of teamwork. Step one, primarily because we were known as a COVID hospital and we had enough ventilators and the pulmonologist and anesthetist who were geared up to manage these cases post-operatively and peroperatively. That was step one. Step two, the ENT, ophthalmology, neurosurgery, MaxFax surgeons, nephrology, physician, radiology, prosthodontist, intensivists, and most important, the pharmacy, which provided us the drugs in adequate supplies. I think in this program, the big chunk of success should go to my MaxFax team without doubt, because at one point of time, I remember I had around 82 patients in the ward at one point of time. And at the same time, we were operating 15 cases in a day. So there was no way that I could have gone and even done the rounds for these people. So taking care of their amphotericin dosages, the cross-reference to other departments wherever there was a nephrotoxicity or hepatotoxicity, doing the rounds regularly, it was all done by the MaxFax team. We hired another couple of additional MaxFax surgeons ad hoc and one more exclusively to write the papers and document, because the numbers were simply overwhelming. Something which we had never expected. That 1 month period was, to say the least, was mind-boggling. I feel the only point I would like to add, I think MaxFax has come a long way. And me and Satyajit had a discussion a couple of years back that more and more MaxFax surgeons should use microscope more and more. But now I am of the opinion, because anyway, you are one of the best examples of expanding your horizons in every direction. More of you people should get used to operating with an endoscope. Because endoscope is not just the domain of ENT or anybody, but believe me, the kind of exposure you get with that. Last week when we were doing an angiofibroma, when Adi was there in the theater, we were discussing how to go and clip the IMAX laterally, and we were thinking of removing the condylar process, going in everything. When we saw it through the endoscope, actually, when we were doing it, we realized that the visualization of the endoscope is simply tremendous. So I feel the younger MaxFax surgeons should look at this seriously. Of loop is one step, microscope is second, but I feel getting used to the endoscope, training yourself and doing it will open up and make your work far more better. I again thank all of you for calling me here to give this brief talk. A special thanks to Girish Rao, and most important, all the MaxFax surgeons I mentioned before. I'd forgotten Srinath's name. I've had a fabulous time with MaxFax surgeons ever since I started my career with Kishore Naik, and I feel they've been wonderful colleagues. Thank you very much.
Can I request Dr. Girisha to please give a certificate of appreciation to Dr. Deepak Haldipur, please, sir. I would like to invite the next speaker for the scientific session of today, Dr. Nehal Patel. Dr. Nehal Patel did his MDS Oral and Maxillofacial Surgery from Mangalore, Fellowship Cleft and Craniofacial Surgery, Fellowship TMJ Arthroscopy from Austria and Germany, Residency in TMJ Arthroscopic and Total Joint Replacement. He currently serves as a director of ABMSS Cleft Center in Surat. He's been felicitated by the German Cleft Children's Aid Society for operated 3,000 plus cleft surgeries. He's been felicitated by the Association of Oral and Maxillofacial Surgeons of India for running 220 kilometers from Rishikesh to Uttarkashi. He's the pioneer in TMJ arthroscopy of India. So we are very honored to have you with us today. Over to you, sir.
First of all, I would like to thank Dr. Girish Rao and Prithvi for inviting me here. I'll be speaking on patient-specific implant for rehabilitation. Now, this is a very new concept and still we are evolving. As you have heard, mucormycosis has actually a devastating effect on the many of the lives, and in our unit we have treated almost 167 mucormycosis. So I'll not waste time. My main topic, I'll come directly on that. Now, after mucormycosis, the rehabilitation, there are a lot of methods and a lot of things which you can do for rehabilitation. But the main thing, where the challenge is, the surgical challenge is basically there is no bone. Then there is a lip support, loss of lip support. And majority of these cases, unlike the cancer resection, this patient, they are closed primarily, buccal and palatal mucosa. So because of that, it creates a unique defect. Basically, it is a unique defect where palate is actually retracted, then is a primarily closed. So this is the challenge we are facing, that it is retracted palate, primary close, then adherence of the palatal mucosa to the nasal mucosa and the sinus mucosa. So to rehabilitate this patient, there are a couple of ways. Traditionally, we have a very well, established method of doing a zygoma and free fibula graft, or maybe vascularized graft. So why to go for a PSI? Now, the reason we started doing this is a couple of things. One is there is a single stage procedure where patient comes only once. We take a CT scan and impression of the lower jaw. Second thing, there are couple factors where zygoma cannot be placed, and where patients, comorbid patient, where the extensive vascular surgery may not be possible. So there has to be some interim way where you can actually rehabilitate this patient. So same way mandible, the mandible is more challenging than the maxilla, because the anatomy which is created by the saucer shape defect after the saucerization of the mucormycosis directly attach muscle from lingual side to the buccal side. So the primary goal of any rehabilitation is, first of all, normal function, minimal morbidity, long-term sustainability, so that patient can go with that prosthesis or whatever rehabilitation method we do for a long time. Replacement of lost volume of bone, minimal rehabilitation time, reduced soft tissue exposure, and withstand day-to-day biting force. Now, there is only one way to replace the volume of the bone, is by doing a free fibula graft. But there are patients where it may not be possible because of comorbid condition. So in those patients, we can start exploring the things. So these are our small data. We started in total 14 Mucor rehabilitation till now we have done, and the oldest patient is around 9 months. So how we do it is, it's a medical grade CT scan. We obtain a medical grade CT scan, convert in a DICOM, design the implant. So the technicality is kept in mind for a surgery and a prosthetic, so that you can place the implant with the minimal exposure. And the prosthesis which is fabricated is in a way that it transmits the force over the larger bony area. So this is the technical detail of the why this type of implant has been created. A two-piece design for the minimal exposure of the area, wide base to cover a strong zygoma, extension on the lateral orbital wall so that you can engage the bicortex with the 15 and 13 millimeter screw. And the length of the bar was kept optimal so that it remains inside the oral cavity but does not impinge on the soft tissue. And there was sufficient space between the two bars for the closure of the tissue. And angulation of bar was given in a way so that when the patient chooses, the entire force is, it distributes the force over the wider area. And there was a small anchor point which was given so that it helps in the initial stability. So this is the design actually, you can place in, and this is a prosthetic technical detail. There was a thread which was given on each cylinder so that you can fix the multi-unit abutment. The placement of the abutment was corresponding to the canine and molar area so that it does not give an anterior cantilever. And there is a self-cleaning area above the prosthesis. And this is a screw retained fixed prosthesis. So this is a bar which is custom made basically according to the patient CT scan, and there's a final prosthesis. This entire design is done digitally, including the prosthesis. The patient has to come only once for the impression and a CT scan. The CT scan, how we take is we apply radio opaque material on the soft palate to obtain the detail of the soft tissue when you get the CT scan. And there are different type of design as when patient required. This is when the partially zygoma also is removed. This you may have to place extraorally. It's a unilateral case where it is away from the midline. Why away from the midline is because if you look at the design, the bar is actually slightly above the attached gingiva. So in this case, you just have to put a small vestibular incision to fix, keeping intact the attached gingiva. And then you can give a prosthesis over the entire 3 stud. This is when there is a midline is present. This extension is given just to give a support of to avoid the cantilever on the opposite side. And that's a surgical technique, very small incision directly over the zygoma away from the duct, complete undermining of the zygoma body up to the lateral orbital wall and FZ suture and root of the zygoma. Then when we actually design it, it starts from above to below, but when you start fixing it, it has to go from below to above. That means you insert the 2 pieces separately, do not fix the implant, then fix the bar, fix the prosthesis, put the patient in occlusion like how you do for IMF. And then you check the adaptation of the implant on the zygoma surface. If your zygoma implant is not adapted, or if there is a small gap remaining between your zygoma and bone, that implant is not going to survive because you need a snug adaptation of those implants to avoid any movement there. So it is like a reverse. So you fix that, and finally you put first 2 screws on the right side, 2 screws on the left side. The idea of putting the screw, usually I prefer to use a self-drilling screw to avoid even the drilling of the holes inside, and it works as a compression, when it goes inside. So then again the bar is fixed to check the adaptation, and closure is done either with the buccal pad of fat, or maybe sometimes you may have to use a mucograft around the stud to generate the thick tissue around this implant stud. And finally, on table, you can fix the prosthesis. So when you take the patient inside the operation theater, basically it is without any bone or the prosthesis, and when they come out evening, they can start eating soft diet. So that's the prosthesis, and that's the self-cleaning area. You can see there is a very small amount of abutment which is remaining outside. That's a unilateral case where, as I said, the incision is not given in attached gingiva, very small incision directly over the bone, and the implant is fixed. This is the prosthesis which is fixed. Now, the problem is in mandible, because as I said, it has been scooped out and lingual bone is above. than the buccal bone. So most of the time what happened, we have to understand when you are putting a metal inside the patient mouth, the mucosa is always giveaway if it is directly underneath it. So to design the mandible, and second thing is the lingual surface. The second thing is the lingual surface where the muscles are directly attached. So if you extend your implant on the lingual side, that surface is going to expose. So what we have done is, if you see the design, it is two-piece design so that it reduces the flexion on the mandible, which can cause a pathological fracture. If you give an entire one-piece design, the lingual side, we kept the 1 millimeter of the bone so that it does not go beyond the lingual bone. The entire assembly goes below the bone. So there are cutting guides. The entire assembly goes below the bone, except for the small abutment which is remaining outside. So when you place the implant, the buccal side of the plate, which goes on the buccal side, the entire implant goes below the bone with the cutting guide. And since there is only one side of the mechanical fixation, and it does not give a tripod fixation, because if you just give on a buccal side, it may rock. So to avoid that, what we have done is we have given a two type of thread here. So in this cylinder on the below, there is a 2 millimeter gap where you can fix the screw directly engaging the lower border of the mandible. And above that, there is a abutment which is fixed. So this is the mandible. After cutting, you can see here, this is a cutting guide. This cutting guide actually reduce the amount of bone. And when you fix the implant, it actually goes below the bone. And that's the screw actually you can see, which is going from the abutment, engaging the lower border. So it is like a tripod fixation, avoiding the lingual side of the exposure. And that's the prosthesis. So we had done, we have done almost 14 cases, and we have a complication. We are still improvising. The first complication we encounter is the loosening of the implant. That is because of the design. We started with putting implant first and then prosthesis. We have changed that now. We start from below to above. There are a couple of screw fractures because of the angulation. So now all the patients we put with the trocar, and we make sure that the screw goes 90 degrees from the hole, engaging the border. One patient has a swelling infection which was taken care just with the local irrigation, has been fine. The longest follow-up we have right now is a 3 patient which we placed at 8 months. And to compare the bending force or the stress ability of this implant, we had done a FES study along with the normal zygomas. If the zygoma is placed normally, the amount of force, bending force, it can tolerate is 790, and the PSI, it came to around 798. So it is almost similar. The biting force, the normal biting force of a human is around 450 Newton. So which is both the zygoma and the PSI has a more bending force than the biting. I'm talking about a normal biting force. If the patient start breaking almond, then it goes beyond that. That is, so we always explain to the patient, if you cut your leg, there is a prosthesis which you cannot run. So this is the same way we are putting something which you can eat, but you cannot break something with your prosthesis. So this is almost 7 months. You can see the well-healed mucosa around the implant, and that's the prosthesis. The second case, again, same. Third case is a unilateral case actually. And that's the mandible after 1 month. Is a nicely formed mucosa. This is a thick mucosa because we place the mucograft around each and every, and that's almost after 6 months. So this is what, see, this is the screw which I was talking. It just engaged the lower border. So each and every screw is well defined before surgery, the length of the screw, so that it goes touching the another cortex. So this is a new science. We are still evolving, and I would still wait for another 2 years for to have those results to say that you can actually go and do with the normal patient also. Right now, we are doing only for the patient who falls in the inclusion criteria. Otherwise, most of the patient they get for either free flap or maybe zygoma. So I think we have a long way to come. This is like driving a EV. When they launch, nobody was buying it because we are very skeptical to explore, we change. And since this is a metal we are placing, we have to understand the metal science also. I have a very good engineer with me who actually taste everything. And my professor is who designed actually the prosthesis. Thank you.
Thank you very much, sir. May I now request Dr. Girish Rao to please give away the certificate of appreciation for Dr. Nehal Patel. Thank you so much, sir. The next speaker of the scientific symposium is Dr. Nagarajuji. He is the alumnus of the prestigious Bangalore Medical College. He is the professor and head of the Department of Ophthalmology in Minto Ophthalmic Hospital. He is the recipient of the very prestigious Dr. M.C. Modi Gold Medal. His special interests include oculoplasty and cornea and reflective surgery. A clinician par excellence, Dr. Nagaraju is popular for his out-of-the-box thinking and ability to deliver at trying circumstances. I now invite Dr. Nagaraju to give his experience on orbital mucor mycosis and ophthalmic perspective.
Good afternoon, everybody. At the outset, I would like to thank Dr. Girish and Dr. Prithvi for having me here. I will briefly run through the ophthalmological point of view in managing mucor mycosis. When I came here, I was really stunned to see so many facial-maxillary surgeons here. Initially, I thought the facial-maxillary surgeons are very few people in number. My initial association with facial-maxillary surgery was only with Dr. Girish. As an oculoplasty surgeon, most of the time we used to manage orbital fractures. Whenever there was an orbital fracture with additional other fractures, other wall fractures, we usually refer to the facial-maxillary surgeon. That was what I thought the facial-maxillary surgeons will do. And over a period of time, I came in touch with Dr. Satyajit. Satyajit, I saw him closely do a lot of sino-orbital surgeries. Then I knew these are the facial-maxillary surgeons who are doing wonders. And it was empowering when I saw Dr. Yamlata Madam and Dr. Prithvi associated together in the management of surgical management of mucor mycosis. I saw what a real facial-maxillary surgeon is. But it is really unfortunate that it took a pandemic like COVID and a mucor fungus to put us together. I think we'll have more such associations in future. I'll briefly give the ophthalmic perspective of management of mucor mycosis. Mucor mycosis is a very dreaded disease, and most of the time it presents to the ophthalmologist only, and it is very important. Whenever a case comes to you, it is very important that you recognize the symptoms as early as possible and make a clinical diagnosis as well as a microbiological diagnosis, which is a must whenever you want to operate a case in almost all the cases. And radiological assistance is also required to know the extent of the disease. And we have to approach the disease on a war front footing, and it has to be very aggressive in nature. So it requires a multidisciplinary team as pointed out by Dr. Deepak Kaldipur. And what is the role of an ophthalmologist in the management of Mucor mycosis? Main thing is the assessment of the disease, the staging of the disease. And our role comes in administration of amphotericin B into the orbit in certain conditions, certain stages of the disease, and in the exentration part and in the follow-up part. So when I think it was on May 16th, on my OPD day, around 5 cases of Mucor mycosis came to the hospital in the afternoon, and our entire Victoria hospital was converted into a COVID hospital, and Bowring also was converted into a COVID hospital. And these patients came, and 3 of them turned out to be COVID positive, 2 were COVID negative. We didn't know where to admit them. So it was then we started triaging the cases, and we put all the COVID positive Mucor into Victoria Hospital and all the COVID negative Mucor. The COVID negative Mucor are those cases wherein microbiologically this RT-PCR were negative, but most of the time clinically they were signs suggestive of Mucor. And that was the phase wherein there was a transition in the clinical diagnosis of Mucor also. There was a lot of confusion at the time regarding the management of staging of Mucor, this thing, COVID itself. So basically we had a working classification like this: a COVID positive Mucor, a COVID negative Mucor, which had all the signs and symptoms of COVID, but they tested negative on RT-PCR, but most of them were positive on CT scan. And we had the third category of COVID recovered Mucor also. Those patients after 14 days were taken as COVID recovered Mucor, and they were also classified. And we didn't get any cases of non-COVID Mucor, even though we had that in the classification. We adopted a simple staging, wherein stage 1 was confined only to the nose, stage 2 the nose plus the sinuses, stage 3 the nose, sinuses and the orbit, and stage 4 with additional neurological involvement. And we add this triaging sheet, and all the cases which came to our hospital were, the details were entered in this pro forma, and a complete clinical examination was done in all the cases, because most of the cases used to turn up to ophthalmologists. They never used to go to an ENT surgeon, and majority of the patient, nearly around 70% of the patients came to us first. After a detailed evaluation, we used to refer the case to the ENT surgeon for admission and treatment. And once the patient was admitted, if the patient had fairly good vision, and of course, all the patient underwent an imaging, an MRI with a contrast on, and in some cases a CT scan also. And those patients with good vision and only mild medial orbital involvement, we used to give only retrobulbar amphotericin B injection. And if the condition deteriorates and if the patient didn't respond, we took the case for exentration. If the patient didn't have any vision and there was an extensive orbital involvement, we primarily did exentration in all the cases. And all the cases which were admitted underwent a complete ophthalmic examination on day 1, day 3, and day 7. More so if they fall into the high-risk category. And even at the time of discharge, they were completely examined in detail. So in the peak of the second wave, we had seen around 429 cases, both in Bowring and Victoria, with male preponderance, and ocular manifestations were seen in around 70% of the cases. And we had 122 deaths. Till yesterday, the statistics of Mucor in our hospital in Victoria, it is around 207 cases with 87 deaths. Bowring, it is around 499 cases with around 80 deaths. And most of the cases presented with these symptoms, which has been detailed, which has been mentioned in detail by Dr. Prithvi. And ophthalmic symptoms are mainly periocular edema, periocular pain, facial pain, periocular pigmentation also, drooping of the lid, protrusion of the eyelid, loss of vision, and limitation of extraocular movements. And surprisingly, most of the cases, even though it is an inflammatory proptosis, most of the cases didn't complain of severe pain. Even though most of them had facial pain and periorbital severe edema, the pain was not as proportionate as we expect in case of inflammatory proptosis. And the early orbital involvement usually results in edema and chemosis. And whenever the optic nerve is involved, there is loss of vision. Whenever the central retinal artery or the ophthalmic artery occlusion occurs, there is loss of vision. Whenever there is a cavernous sinus involvement or intracranial involvement, we get all this nerve palsies and bloody nasal discharge and other conditions. So in between, in around 8% of the cases, we had a case. This is the father of one of my residents, and a 61-year-old male with very good preserved vision, presented with classical symptoms. He was COVID positive, severe, with was on oxygen for nearly 1 month. He had a lot of nasal crust. On endoscopic evaluation, it turned out to be aspergillus. So these were all the other fungal elements which were in play along with our Mucor. And at that time, in the month of June, our Indian Journal of Ophthalmology published this document, a code, Mucor it is called, and it gave us guidelines regarding the staging of the disease, and it gave us rough guidelines about the management of the disease. We adopted these cases, this particular code Mucor, and basically it classified the ophthalmic Mucor into 3 categories. One is the probable, possible, probable, and the proven. Possible is the patient presents with a ophthalmic manifestation, and the patient is in a classical COVID setting. That is all the things what was described in the 3rd slide of Dr. Prithvi's presentation. In probable, it is the clinical diagnosis along with a radiological diagnosis with a endoscopic visualization also. That probably there is an involvement of the sinuses. That was the probable Mucor. And proven Mucor were those cases wherein you confirm the presence of the Mucor element by microbiological methods. And this was the staging system. Stage 1 is predominantly renal here, the first one. And basically that, stage 1 is predominantly the nasal involvement. And the first stage, the place where it occurs is in the middle meatus. And later it can spread to the nasal septum and the inferior turbinate also. And in stage 2, we have got along with the nasal involvement, the paranasal sinuses also getting involved. And in stage 2D, we get involvement of the palate. And stage 3 is the orbital involvement, which I tell in detail. And stage 4 is involvement of the central nervous system. Majority of our cases fall in that is in our setup. We saw a lot of rhino-orbital cases, which were seen in around 48% of the cases. Stage 2, that is rhino-sinal, around 40% of the cases. Most of the, if you subclassify and see, most of the cases fell in the category 3B, and the second next category, what we saw was 3C. So how does the Mucor, which is staying, wherein the primary attack is on the nasal mucosa, affect the orbit? See, a Mucor which is present in the nasal cavity, that falls in the stage 1, and through the retrograde spread through the nasal lacrimal duct, it can spread into the orbit. So even if the patient has got a stage 1 disease, the patient can present with an orbital mucormycosis. Initially it can be mild, then gradually it can be severe. The other route by which it can enter into the orbit is through the medial wall of the orbit, that is the lamina papyracea. Through this, it can easily enter into the orbit through the lamina papyracea. It has been seen that in around 40% of the cases, there is bilateral sinus involvement. That is why we see some cases of bilateral orbital mucormycosis. And this is a classical case of mucormycosis wherein only the sinuses are involved. This will fall into the category stage A, wherein only the sinuses are involved and there is a very mild congestion. And if there is a palatal involvement, it falls in the category of 2C. And ophthalmic involvement, stage 1 is involvement of the nasolacrimal duct. The patient will present to you with a very mild lid edema and a very minute congestion, conjunctival congestion, which we see sometimes on the medial side and the lateral side, and the vision is unaffected, and the patient's extraocular movements are absolutely normal. And stage 3B, there will be extensive involvement of the orbit, and more than 1/4 of the orbit will be involved. Sometimes one or two structures, more than 1 or 2 structures in the orbit can also be involved. And in this case, the vision is also not affected. These 2 categories we can easily manage with intravenous, with intraorbital amphotericin B. Stage 3 results in vision loss. It can be either due to the involvement of the central retinal artery or the ophthalmic artery, and it can spread into the orbital apex. It can spread into the superior orbital fissure and the inferior orbital fissure, and it can extend into the brain if left untreated. So this case falls in stage 3, wherein the patient presented with puffiness of the lids and drooping of the lid, what we call as ptosis. And some cases present with say, severe chemosis. What we usually see in allergic conjunctivitis, a diffuse chemosis, we can see that is because of extensive orbital involvement. Some patients, involvement of the orbital apex can produce a decrease in the vision. In addition to that, extraocular motility disturbances also. And extensive orbital involvement can result in a picture presentation like this with proptosis. This is a classical case of central retinal artery occlusion because this is a fungus which will invade the blood vessels and that will produce thrombosis and produce loss of vision. And we used to see many cases like this wherein the periorbita is involved with lot of HR formation. Bilateral orbital involvement also was seen in some cases, and some of the cases can be because of bilateral sinus involvement, or it can be because of extension through the intracranial route also. So how do you manage these cases? So according to that code Mukar document, we classified the disease into possible, probable, and proven ROCM, and we adopted this line of management what they proposed. And basically for all stage 3A and stage 3, I'm talking only about orbital mucormycosis, we administer retrobulbar amphotericin B, and we used to follow up the cases periodically. And if the condition deteriorates, some of them ended up with exenteration, and most of the exenterations were in the stages stage C and D. Retrobulbar amphotericin B injection through the transconjunctival route, the dosage recommended is 3.5 milligram per ml. And initially we used to use the liposomal variety of amphotericin B. Later on, what usually happened was this was not available, so we used the deoxycholate form without any side effects. And this is how we administer the amphotericin B into the medial orbit. And in our experience, we had given around 107 cases of amphotericin B transconjunctivally. Some cases went to a dose of up to 7 doses. In 35% of the cases were COVID cases at Victoria Hospital, and 65% of the cases were COVID recovered cases at Bowring Hospital. And what we noticed was there was no significant improvement in the visual acuity. And however, there was proptosis resolution in around 5% of the cases and improvement in the ocular motility in around 20% of the cases. And once these cases progressed, those cases which didn't respond to your amphotericin B, we went in for exenteration. Our indications were wherein the medical treatment failed, unilateral cases, wherein there is significant fulminant orbital involvement, and where sometimes some cases had a non-salvageable globe. Some of the patients had an eye which had an exposure, proptosis, secondary infection, and whenever there was extensive necrosis and thrombosing vasculitis, these were our indications for exenteration in the COVID scenario. And we did both lid sparing and lid sacrificed and some lid sacrificing exenteration. And basically all the cases were taken up under general anesthesia. Sometimes the ENT people used to do the FESS surgery, and we used to do the orbital exenteration, and side by side the facial-maxillary surgeon used to chip up. And we should really thank the anesthetic team of both Victoria and Bowring for being with us throughout the procedure. And this was the exenterated specimen which has been taken from one of our cases. And the most traumatic part of this thing was this exenteration was not only traumatic to the patient, it was also traumatic to us also, because we have never done so many exenteration. Basically, ophthalmologists, we are considered as very mild people. We do only aesthetic things, and only during managing malignancies, we were doing exenterations, and we had to do in relatively younger patients. Most of the patients we saw were in the age group of around 45 to 50 years, and we had to do this exenteration in those cases, and it was traumatic to us also. And most of the cases we had lid sparing, exenteration, and we had to do this dressings also. And doing these dressings for nearly 3 to 4 weeks, almost on every alternate days. Some of the residents were complaining this is very traumatic to them also, but of course, all of them chipped their part in, and these are some of the results, good results we got. We can see the healthy granulation tissue over there. And this is one case wherein the lid is spared, and the other one is the lid is sacrificed. And our exenteration experience is we have 41 cases were done, and around 6 cases we lost in the follow-up. 35 cases were included. 18 cases we did the lid sparing exenteration, and most of the time the lid sparing exenteration, the medial part used to gape, and we had to resuture it. And when in the lid sacrificed exenteration, most of the cases healing took place very well by spontaneous granulation, and that granulation usually used to start at around nearly 2 weeks itself. Usually it's used to start in the medial part of the orbit, medial orbit, and over a period of time the lateral orbit, and most of the time by 4 to 5 weeks the spontaneous granulation used to take place really well, because most of the patients were in the younger age group. Unlike what literature says, they say nearly it takes around 2 to 3 months for your spontaneous granulation to occur and for the wound to heal. And survival post-exenteration period at the end of 1 month without intracranial spread, around 26 patients survived out of 30, and around 4 with intracranial spread, they survived out of 8 cases. And this is what I told, that is the healing by granulation tissue. And at the end of 4 weeks, most of the cases had very good granulation tissue. And this was an attempt towards rehabilitation of our patients. And it took some time for our entire Victoria Hospital, Bowring Hospital, and Bangalore Medical College to come back from COVID to non-COVID. After that, there was a deluge of cases. Our oculoplasty departments were flooded with our routine other cases also. So we usually used to refer the case for rehabilitation to the plastic surgery department of Victoria Hospital and the Government Dental College. We had a good team who could make this for us. These were our attempts to towards rehabilitation, cosmetic rehabilitation, to improve the psychological well-being of our COVID patients. And this present conference is really a illuminatory experience for me, because there are a lot of other techniques which I was not aware of, which will be useful for these patients. And I would like all of you to just go through this document. This is a document published in our Indian Journal of Ophthalmology. From 22 states, data was collected of 2,826 patients from around 102 treatment centers, and the epidemiological, clinical profile, and the management and the outcome were analyzed. And based upon this, they have given some guidelines which will be useful on future. And this meta-analysis study has been appreciated by the American Academy of Ophthalmology, and we have contributed to this study too. Thank you very much.
Thank you, sir. May I request Dr. Girish Rao, sir, to hand over our certificate of appreciation to Dr. Nagaraju. Thank you, sir, for that wonderful talk. Our next speaker is Dr. Anand Krishna GN. Dr. Anand Krishna GN is a renowned prosthodontist and implantologist with extensive clinical and teaching experience in the field of implantology and complex restorative protocols. He finished his bachelor's degree from GDC Bangalore and completed his master's in prosthodontics and implantology from A.B. Shetty Memorial Institute of Dental Sciences. Dr. Anand Krishna is the first board certified prosthodontist from the Indian Board of Prosthodontics, a diplomate of ICOI. He has been in academics and has served in various institutions, his last tenure being the professor in MS Ramaya Dental College. Sir has occupied various designations at several national and international organizations. Some of them include Secretary of the Indian Board of Prosthodontics, Secretary of the Indian Prosthodontic Society, Ambassador of ICOI, Vice President of Indian Prosthodontic Society. He was also the Secretary of the Karnataka Prosthodontic Society, Scientific Coordinator of ICOI South Asia, and an Executive Council member of IPS. Sir is the founder of My Dental Plan Healthcare, 3Dent Digital Dental Solutions, and Implant Study Group. Sir has been trained extensively in the field of crown and bridge and implantology, He has vast experiences in implant prosthodontics, including various systems of implant systems. May I now have the pleasure of inviting Dr. Anand to share his experience on prosthetic rehabilitation of mucormycosis.
Thank you, Dr. Swaroop, for those kind words. Let me just get this thing going. Starting to see. Check. Good afternoon, everyone. It's still heartening to see some participants still in the audience. I see more of my colleagues, my seniors, and dear friends than students, but this is the state of affairs in every society. I'm a prosthodontist, and it's very intimidating for me to speak in a surgeon's conference, because everybody is talking about rehabilitation, restoration, and somewhere we prosthodontists also in some way contribute to this larger cause. So my whole purpose here is to try and impress on you what, as prosthodontists, what we can do. More than that, what we expect our surgical colleagues to do, certain small modifications in the way they resect, and how it helps a long way in the way we finish the prosthetic work. So that's the whole purpose of this. These are my various associations, of course. And this is what was the original plan on Jan 22nd of this year. We wanted to do the same program in Bowring Institute, courtesy Dr. Hemlata and Dr. Manoj and everyone, based on prosthetic rehabilitation of Mucor cases, but we were not allowed due to the COVID protocols which were prevailing. And here we have the Maxillofacial Society doing the same thing at, I think, a much larger scale than what we would have done. So objectives of this presentation is to describe how Mucor cases present and what is the initial challenges that we have, how we treat them initially. Going forward, what is the types of prosthetic protocols that we follow? Of course, Dr. Nehal Patel had to leave, so he spoke out of turn. Otherwise, his was the desert. Okay, mine is just the starters. Then Sankalp is here, who is going to talk a little more extensively. Of course, Dr. Satish. They're all the main course of surgical things, but we do the starter bed and see how we can actually rehabilitate these patients. To discuss prosthetic protocols in these defects, to identify what a favorable defect is and what an unfavorable defect is, because this is a territory which most surgical specialists actually debate themselves. Should I remove? Should I not remove? Is it too much that I'm removing, or things like this? So we will talk a little bit about it to identify some surgical modification which can benefit the outcomes. So the challenges in maxillary defects is oronasal communication. Many speakers have spoken about it. Inability to swallow, eat, and drink. That will be the initial thing that we want to address. Hypernasality of speech. Reconstruction is not mandatory to rehabilitate some of these defects. So let's talk about more practical solutions for a wider perspective of wider range of patients, then probably we can do reconstruction and rehabilitation with implants and patient-specific implants for that small segment of patients. Yes, it's an improved quality of life can be obtained by a well-fitting prosthesis. So once we started seeing cases in Bowring Institute, we typified these cases. We divided the cases into partial and fully edentulous patients. We saw the defect and say this can be a favorable defect, this is an unfavorable defect. And sometimes, most of the times they have done primary closure, which we don't see in actually patients with malignancies. We don't see primary closure on the local flaps being approximated. Generally, we see either a regional flap or a remote flap being done. So here was a condition where they were doing local flaps and the buccal and palatal mucosa was being closed. Whether this is good? Yes, for disease progression, it helped really well in the initial healing, but from a prosthetic perspective, the story is totally different. So the way that you would approach a favorable defect, an unfavorable defect, and a defect with primary closure is three different things. For example, if you have a primary closure and it's intact and it has survived for 6 months, then you do what is called a ZIP protocol, a zygomatic implant perforating the flap kind of protocol is what you do. But if it is a favorable defect, a good well-fitting obturator can do the trick. If it is an unfavorable defect, probably you will have to do some small surgical modifications to make it favorable so that we can deliver our obturators better. And of course, you had the complex defects, which had a intraoral plus extraoral type of defect. So let's see some of these things. This is where we see on the left-hand side, though the defect is less extensive, this defect is an unfavorable defect. For example, on the left side, you have the two compartments which are there, which is bridged by a thin kind of mucosa in between. This is a total no-no for us as prosthodontists. We would like the defects to be something like this. So this defect is more extensive. This is a more doable case than that. Okay, we can initially manage that, but going forward, the path of insertion of the two bulbs on bilateral sides will be so unfavorable. You will start seeing results of this in a short while. You'll get friction in the mucosa. You'll have tearing of that small bridge of mucosa, which might be there, and so many other complications of the process itself can be what is seen. When you look at the partial cases, the presence of teeth and the presence of pre-maxilla is something which is going to make it very favorable. A defect which is like this, probably with a lot of undercut, very small opening and a wide base, something like that is very unfavorable. We cannot get good amount of contact with the tissue. We cannot get a good seal. So these will be unfavorable defect. That will be a favorable defect. The favorability of the defect does not depend on the extension of the surgical intervention. It is the nature, the way the undercuts are, the way the teeth are present, the way the configuration or the anatomy of that particular defect is very much important from the prosthodontic perspective. So here we have just made favorable and unfavorable. As healthy teeth present on the non-defect side, if it is healthy, we can just do definitive obturators with cast partial dentures, cast partial frames. It works very well. We have follow-ups of almost about, me and Dr. Girish, we work together. We have follow-ups of almost about 20 years for some patients who have had cast partial denture supported obturators or a hollow bulb obturator. Worked very, very well. It is very predictable. They've not undergone any reconstruction or rehabilitation in any other way simply because they were all malignant cases, but we were able to do this on a long-term basis. Defects with a large opening and a narrow base, no flaps and additions in the middle of the defect is favorable. If it is bilateral, the line of draw, you should think almost like a structural engineer, whether the line of draw and path of insertion and removal, like a prosthodontist in the other ways, okay? Whether it is actually favorable or not, okay? Unfavorable is multiple defects, no line of draw, bilateral narrow defects, soft tissue over the defect, which is very flabby. Here we are talking about denture bearing area, if any of you remember from your undergraduate days. Okay, so that it has to have a kind of adherence to the underlying tissue. Otherwise, your dentures are going to just move. Your obturators are just going to move. So it's very unfavorable to have a kind of primary closure with a very flabby tissue. You might as well have a defect for us to rehabilitate. Composite defects with external extension is a complex defect. So this is how the other presentations were. This was a complex defect. On the right-hand side, you can see it looks like a well-formed ridge, but there is no bone underneath. These are cases which have a definite indication for quad zygomas. Okay, that is what Sankalp is going to speak about in the next few days. Options, obturators. Yes, first of all, we have to think of the feeding plate where there is some kind of immediate solution, then an immediate obturator, interim obturator, and a definitive obturator. The difference between the interim and the definitive obturator, both will look the same. The definitive obturators are made by cast fascial frames. The bulb is definitive because there is not much of shrinkage that is happening. So you do it after about 6 months after the defect has been done. Reconstruction using bone grafts and soft tissue flaps, restoration, closing of the defect with a flap, implant-based treatment like zygomatic, pterygomaxillary implants and implants on the normal side to enhance retention. These are the options that you have for rehabilitation of maxillary defects. Let's see some of these. This was a patient which we saw in Bowring Hospital. He was a young gentleman, bilateral maxillectomy. What we did was when Dr. Hema called me and said, look, this guy is not even able to swallow anything. I said, like, why don't you just make an impression with the impression tray with some putty or some impression material and just allow him to swallow. Get him off the Riles tube, ask him to just keep that in place and just swallow with that. Okay, this acted like a feeding plate. It was fitting well. He just was holding it with one hand and then using the other to just basically feed himself. This was another defect, and this you can see an immediate surgical obturator. This doesn't have a bulb. It just has no teeth or anything. It's just extension. This at least require a single day for you to actually go ahead and do this. It might not be great fitting. It's just that you have gone ahead and done something for the immediate need of the patient. This you can go ahead and modify this. You can attach a bulb onto the same thing or go ahead and just duplicate that in order to make an interim obturator. The design of the interim obturator is also very important. I don't know, it's just gone away. So you can use some clasps. These clasps have to be slightly thicker than the orthodontic wires. It has to be at least a 1 millimeter clasp. You can also use a flange retention. Instead of just clasp retention, you can use the whole flange on the buccal side and make it retentive. There are many ways of doing it. And this is how it works on patients. You can also reline it from time to time and make sure this remains in place. This was another patient of ours, an old patient who was wearing an immediate surgical obturator and an interim obturator. We placed some implants on the other side for retention. And you can see this is a definitive obturator. It has a metal base and it has a huge bulb till wherever you want to extend. The extension of the bulb is very important for us because the hypernasality of speech is reduced. There is seal. There is no oronasal communication. You try and engage the lateral aspect of the defect, preferably a skin graft. I know in Mucor, a lot of surgeons are not doing skin grafts, but if it is a cancer case or going further, you could think of a split thickness skin graft on the lateral aspect for us to go ahead and engage, and you get superb retention in this. The cast fascial framework itself will give you measured retention, because in a clasp wire, you cannot know how much retention you're giving, and you're going on tightening, and you might compromise the abutment teeth itself. Here, you know exactly how much of undercut to engage, and you're going ahead and using that to hold the prosthesis in place. And that is how we were able to rehabilitate this patient. Implant retained obturators, you can just, for completely edentulous patients, it's a big boon. You cannot do it without implants here. You'll have to just place 2 implants and make an overdenture. I think this is going off again and again. I think I'll just stay here. I don't even move so that sticks. Okay, so you place a couple of implants for the retention of the obturator. No, again. Please. Yes. You didn't use my word, huh? So you just place 2 implants to hold on to the obturator. That would be more than adequate. And you can see a dramatic change in the way this patient will function from a completely edentulous patient to an obturator which is implant supported. Implant retained, it's not supported. For a more extensive defect where the pre-maxilla is missing, these are more complex defects in our jargon. You can place implants in the pterygomaxillary area, like in this case, how an implant was placed with whatever remaining area of bone that is available. You go ahead and actually place the implants and then just give overdentures. Whether this is the ideal treatment from a prosthodontic principle, no. Whether it's a practical treatment, yes. We are trying to be as practical as possible. We also made some silicone bulb obturators for this patient who had an extensive kind of a bilateral defect all the way there, and we were able to rehabilitate that. Reconstruction with implant supported process. Yes, I know Dr. Sankalp will be speaking on the implant modalities. This is a short video as to what we do as planning. Okay, from a prosthodontic perspective, how you can go ahead and plan this on a guided surgical software is what I'm trying to show you here. These are data sets which we are importing into a software called as DTX Studio. We have just imported the patient data set here. The DICOM files are imported, and you can see that there is a unilateral defect which we are trying to put some implants in. This is the orientation of the jaws, and actually what part of the jaw you want. You're going to toggle and remove the portions which you don't need. Now you can visualize the zygoma even better. You're going to place some implants there. You can put 2 implants into the zygoma, and probably if any bone is left in the pterygomaxillary area, you can add an implant there, or if you have some bone above the teeth on the premaxillary area, you can also place some implants there, and then you can actually go ahead and execute this. So what happens is when you place the 2 zygomas, there's hardly enough space. You're going very close to each other. The idea is you want to get a spread. Okay, it's just not putting 2 implants into the zygoma. It's trying to get the spread. We call it as anteroposterior spread. When you put 2 implants, it has to be further away from each other so that you can put a bar and clip on that. If it is a defect like this, if it is primarily closed, then you might as well go ahead and give a fixed prosthesis onto this. There is nothing that is stopping you. So you are evaluating, you are visualizing, you are going ahead and making this, and then you convert this into a stent so that it's easier for your surgical specialist to visualize and place these implants very accurately. So that's the way you're going ahead and doing that. And when you have a case, something like this, where you have quad zygomas, which is 2 zygomas on either side, this is something which is again of a challenge. Again, the same principles. You want to place the heads of the implant, not the tip of the implant. The tip of the implant can be close to each other, but the head of the implant should be farther away so that you have the anteroposterior spread and much more stability for these kind of restorations. How do you improve the outcome? First of all, the skin graft, which I was talking about, maintain access to the defect. That is, the body of the defect should be larger than the opening should be very large than the apex. That is when you will get a good seal. Salvage pre-maxillary segment, evaluation of the primary retentive teeth. Many a times we see that there is a loose lateral incisor, which is the primary retaining teeth. In the sense, just adjacent to the defect, the tooth is called as a primary retentive teeth from the prosthodontic perspective. So if you have a lateral incisor, it's better that you eliminate that lateral incisor and probably put an implant or give the central incisor as a primary retentive tooth or a canine. Surgical cut should be made in such a way to spare the tooth supporting bone, because sometimes the cuts are so close that the alveolar process the root is getting perforated. So those are questionable abutments for us, and of course, placement of implants. These are some of the happy smiles that we had from the Mucor cases. So I would want to place on record some of the acknowledgements. So we had treated about 120 cases altogether for rehabilitation. Of course, Dr. Hemlata and team, big kudos to them. They have organized the whole thing so well. They have typified the cases. They have located the cases, like geo-mapped the cases. Oh my God, that's super. Because we were using 8 centers to do these cases, because every single visit of a maxillofacial surgeon approximately converts to about 20 visits for a prosthodontist. That's the ratio, okay? So it's almost humanly impossible for us to treat 120 cases with that many number of appointments. It's almost impossible. So we had to make use of these 8 centers where the students, the staff, the heads of departments were very, very forthcoming. This is one time that everybody took ownership to this cause, in the sense, it's just that, oh, it's just not another case. Well, this is a case which we have to treat. So they came forward, they treated and they rehabilitated, and it was such an enriching experience for us. And thank you for making us a part of this whole rehabilitation team. Thank you, Dr. Hema. Thank you. Thank you, Dr. Girish Rao, and who's like my elder brother, and to all the AMSI team for giving me this opportunity to make a small presentation. Thank you.
I would request Dr. Girish Rao to kindly hand over the certificate of appreciation for Dr. Anand Krishna. Thank you so much, sir, for gracing this occasion.
Thank you, sir. Next up, we have Dr. Satyajit Dandagi. Dr. Satyajit Dandagi is an expert maxillofacial surgeon with specialization in free vascular flaps for oncosurgery and reconstructive surgery. To his various credits, he has various achievements to his credits, which include the member of being in the medical aid team in the Gujarat earthquakes 2001. He has won the best paper in the delegates category in AOMSI conference in Bhubaneswar. He has been invited as the guest speaker in the Plastic Surgery Association of India in 2016. Sir also is the recipient of the Maxillofacial Surgeon of the Year award in 2017. Sir currently serves as a professor in PMNM Dental College and is a consultant maxillofacial and reconstructive surgeon in the Cord Road Hospital, Bangalore. We now request Dr. Satyajit Dandagi to give his experience on microvascular reconstruction of mucormycosis defects. So.
Audible? Yeah. It's quite late for the lunch as well, so I'll try to finish it at the earliest. Thank you, Dr. Girish Rao, AOMSI, for this opportunity. before I begin, Mucor mycosis peaked and lasted for few months. But the burden of the rehabilitation of these unfortunate patients who survived will last for a few years, hopefully. Now, reconstruction of the Mucor defects. What is the difference between the reconstruction from the oncology or the post-trauma reconstruction with the post-Mucor defects? The timing, it's always going to be the secondary reconstruction. A minimum waiting period of 6 months post-treatment without signs and symptoms of any Mucor recurrences or any other, the bone that is left behind should not be sequestrating. The disease assessment is clinical evaluation, CT scans and MRIs to rule out any necrotic areas. And the quality of the quantity of the recipient bone also has to be analyzed before you plan for any reconstruction or maybe implant-based rehabilitations as well. I have not really classified the defects, but just to simply soft tissue defects, the hard tissue defects, and majority of the times they are combinations. What are the prerequisites for the Mucor bony reconstructions? Non-necrotic, good bony zygomatic buttresses or any of the buttresses to receive at least one side of the bony free flap. At least one side has to be there, otherwise it is not possible to put a bone there. Reconstruction, you have to have CT scans, the 3D printed models, which is easily available in any cities in India. Ultimately, the end point of all these reconstructions has to be the functional rehabilitation. So being more practical is important than being idealistic over here. Now, what are the technological advances that we use is customized plates and screws. We already gone with customized patient-specific implants. The fibula cutting guides for the precision of the bone cutting, and a two-stage fibula where you put a bone graft into the donor site onto the fibula and then get them into the, once the skin graft is accepted 10 days down the line, you can get that entire thing for the prosthetic rehabilitation. But there is a flaw in that. If associated soft tissues are there, putting a soft tissue defects are there, then putting a skin graft on that will not, you will not be able to get a soft tissue to obliterate that soft tissue defect. Now going through a couple of cases only, soft tissue defects. This is one of the cases where she had suffered from the Mucor in the first wave probably, juvenile diabetic, and this is how she presented in the beginning. She was given a temporary obturator by the prosthodontic department, and she sustained that for some time. And 9 months down the line, we took her up for the reconstruction. This was the defect that was being created, and the neck incision to expose the vessels in the neck. We used what is known as for non-surgical people, it is a free microvascular radial forearm flap, along with the radial artery and the cephalic vein. So this is the surgical procedure of the harvesting of the free radial forearm flap. And then the skin was used to cover the defect, and the neck vessels were dropped into the neck where it is anastomosed. And we used the auricular cartilage to get this ala right over here, to get this ala right over here. And to avoid the collapse of that ala and the nasal complex, we used a plastic suction tip just so that to avoid the collapse. And this is 15-20 days down the line, and this is how we are able to reconstruct the ala as well as the nasoalveolar complex. And from here to here, we got a follow-up of around 3 months. So this is the defect what she had. Sorry, this is the defect what she had, and we are able to rehabilitate or reconstruct this nasomaxillary defect with a free radial forearm flap. So that is a soft tissue defect. Now going on to one of the cases where it is He's my close friend on that matter, my childhood friend. Suffered non-diabetic, suffered with the Mukar because of the inadvertent use of the steroids. Had left a maxillary defect. This is the defect that what we had. And then we did wait for 7 months. This is the kind of defect what he had. Yes, what everyone was talking about, this was primarily closed. So the buccal flap was close to the palatal flap, and then he had that cicatrization, and the contracture was to the higher side. And this was the planning CT scans. And we planned at least one side, there has to be a bony strut so that the free fibula flap that we're going to engage will ultimately fuse to the donors or the recipient site. And over a period of time, it becomes a part of the maxilla and easier to rehabilitate. Microvascular fibula flap was harvested. This is the planning. And we had used the skin also to close the some soft tissue defect. This is a representative diagram on one side and the fibula harvesting. And yes, we do use 3D printed models. We do pre-plan for the prosthetic. It is always the reverse planning. The dentition is planned first, and then the bone is placed in that order. But while executing, it is the bone is placed first, and then the implants and the rehabilitation is done at the end. So this is the pre-bending of the plates and screws. The plates and the screws are adapted there. And after the harvesting the free fibula flap, the pre-bent plate or the customized plate is used. And we osteotomize the fibula to get into that shape. This is the vessel over here that will drop down into the neck, and then it is anastomosed over there. So this is the post-operative 1 month down the line. This is how the post-operatively it is yet to fuse. All the segments are yet to fuse, but this is how the post-operatively the patient looks. Okay, from here, this is the before the surgery.
ಮೇದಲ್ಲಿ ಇನ್ಫೆಕ್ಷನ್ ಆಗಿತ್ತು, ಬ್ಲ್ಯಾಕ್ ಫಂಗಸ್ ಇನ್ಫೆಕ್ಷನ್. ಜೂನ್ 10ನೇ ತಾರೀಕಿಗೆ ಆಪರೇಷನ್ ಆಗಿದೆ.
ಮತ್ತೆ ಈಗ ಎಷ್ಟು ತಿಂಗಳಾಯ್ತು?
ಈಗ 6 ತಿಂಗಳಾಯ್ತು. 6 ತಿಂಗಳಾಯ್ತು ಈಗ. ಜೂನ್ 10ಕ್ಕೆ ಡಿಸೆಂಬರ್ 10ಕ್ಕೆ 6 ತಿಂಗಳಾಯ್ತು. 6 ತಿಂಗಳಾದ್ಮೇಲೆ ಈಗ
ಏನು ಪ್ರಾಬ್ಲಮ್ ಐತಿ?
reconstruct
like all the patients, he also had a problem in speech and swallowing. You could hear that. Okay, now this is the post-operative video just recorded.
Good afternoon. After post-operation, my appearance and my speech is well better than before, and I can speak properly, and the doctor assured me that within a couple of months, they will implant the teeth and my life will be as normal as earlier.
Look at the confidence that has made a lot of difference. He has joined back his work as well. And from here to here, that is a free fibula, and his appearance, aesthetic as well as functionality is brought back from here to here. And then this is not one of the defects where it is not a Mukar case, the post-trauma, just to show how bad can be the defects and how it is possible to reconstruct and rehabilitate. This was a blast injury, a soldier, and we big oroentral nasal and orbital communication. And he was reconstructed with a free microvascular fibula. And then this is how you can see over here. Once it is 3 months down the line, we place the implants. In fact, the rehabilitation was done by Dr. Prithvi and Nisha Shetty. Excellent rehabilitation has been done. So you can see the post-operatively, the dentitions have been given with occlusion, functional rehabilitation. And Mr. Atkins took care of the orbital processes as well. So you can see the excellent orbital processes over here. And we were able to close that, get that orbital processes, we were able to close the lid also there, put some flap and skin graft over there. So from here to here, so it is not one person's job, entire team gets involved, right from the the reconstructive team, the prosthetic, and then ultimately the technicians as well. So reconstruction of the Mucor defects. So what are the limitations what we have? If we don't have any buttress, not even a single, then it is challenging to do the bony reconstruction. If no bony reconstruction is, then how important it is to get into rehabilitation. Sankalp and Anand Krishna and even Nehal spoke about the patient-specific implants, so they can be brought in. These are the alternatives that what we have, the zygoma and the patient-specific implants. Reconstruction of the Mucor defects, why free flaps? Yes, this was the study. What I'm going to show is a PhD thesis submitted by a Marine. We were a part of this study. What it showed is that need for free flap reconstruction evaluated between the normal speech, the speech with the obturators and the speech with the free flaps. What it shows is that whenever there is a free flap reconstruction, immediately you can see over here the percentage of correctly produced conocents and the correctly produced ovals. And whenever there is a free flap used, it almost matched the normal patients over here. And then this is the speech intelligibility rating score. This was analyzed with the computer assistance. With the obturator, the score was 4.5. With the reconstructed microvascular flap, it was close to the neurotypical group. And she submitted, it was part of it was helped with in assistance with the KIDWAI, we were part of it. And this is the PhD thesis. So if feasible, try and get free flap over there. If it is not feasible, then the other alternative options are also there. The post-Mucor defects and the deformities are going to haunt patients, society, and the medical fraternity till the last patient is being rehabilitated. We need multiple ways to rehabilitate and bring all these unfortunate patients to the mainstream society. Let's join hands for this cause. And thank you for this. Acknowledgements. Thank you for the entire team, the dental college, my department staff in PMNM Dental College as well. Thank you very much for the patient listening. Thank you, sir.
Thank you so much, sir. May I now request our Honorable General Secretary, Dr. Girish Rao, to please give away the certificate of appreciation to Dr. Satyajit Dandagi. Thank you so much, sir. Thank you, sir. It gives me immense pleasure to invite on stage Dr. Sankalp Mittal. He is a professor and oral and maxillofacial surgeon and implantologist and in charge of the implant clinic in Government Dental College, Jaipur. He did BDS from SMS Medical College in Jaipur and MDS OMFS from Manipal College of Dental Sciences, Manipal. He is a life member of IDA, AOMSI, Academy of Oral Implantology, and Indian Society of Oral Implantology. He is a fellow of the International Association of Oral and Maxillofacial Surgeons. He has been awarded as the Diplomate of International Congress of Oral Implantology, first in the state of Rajasthan, Diplomate of World Congress of Oral Implantology in Japan, Diplomate of Academy of Oral Implantology, Fellow of Oral Implantology, India, and he's also the member of the Royal College of Surgeons and Physicians, Glasgow, UK. He is working as the assistant professor in Government Dental College, Jaipur since 2005. To his various credits, he has pioneered oral implantology in Rajasthan since 2004 and extensively worked on zygomatic implants. I now request Dr. Sankalp to give his experience on zygomatic implants in mucormycosis patients. Over to you, sir.
हेलो ये ऑन है So good afternoon, everybody. And again, at the onset, I would like to thank Girish Rao sir and AMSI for giving me this wonderful opportunity to share this, share my experience on zygomatic implants in the management of mucor mycosis defects. And being as a last speaker, I have the liberty to speak up to whatever time I want, because now only two types of audience are remaining: those who are really interested in the topic, and second, those who have to log the hall. So my apologies to those who want to log the hall. I'll just extend for 5-7 more minutes so that I can justify the topic. Why I want to, I'm saying that I want to justify the topic because we have seen many type of rehabilitation methods of mucor mycosis defect. And I just like to say all the postgraduate and the younger surgeons that zygomatic implant is one of the most easiest, less complicated, and the fastest way to rehabilitate the mucor patients. Rest other things, whether it is PSI or whether it is a microvascular surgery, you need much more specialization, much more planning, and need some more time to rehabilitate them. So when we talk about the defect which has occurred after the mucor mycosis, it can range vertically as well as horizontally into various types. And usually it is the low level defects which we are interested in. So low level defects can be easily treated with the zygomatic implants. For higher level defects or the mid facial defects, you have to go for a microvascular surgery or other prosthetic options. Similarly, when you talk about the horizontal defect, of course, if it is a mid palatal defect, there is no role of implantology. And those defects which are extended bilaterally, whether it is partial or full maxillary defects are there, they can be easily treated with the zygomatic implant. But the problem occurs when the defect is unilateral and it is confined to one part of the palate and some natural teeth are present there. These are one of the most difficult cases to be treated with the zygomatic implants and the prosthesis. The reason behind that is you want to save the natural tooth also. And when you want to place your zygomatic implant as close as possible to the natural tooth, the distance between the natural tooth and your zygomatic implant, zygomatic bone is too less to place your zygomatic implant to a proper position. Because the drills are longer, apart from the drill length, the handpiece length is also there. So most of the time you end up placing your zygomatic implant in unilateral cases slightly away from the natural tooth. So it gives you a, this is anterior implant, this is posterior implant. So it gives you a cantilever ahead of the anterior zygomatic implant. So in these cases, either you combine with these two zygomatic implant with a pterygoid implant or with a anterior implant. So, or with the anterior implant, either by extracting the tooth or by putting it in the palatal bone. So we have usually two types of defects, either only dentoalveolar defect, which can be easily treated by the prosthesis implant supported, or it could be a composite defect, that is dentoalveolar defect along with the palatal mucosa defect or the buccal mucosa defect. So the problem arises when it is a complex defect. So now you have various options to treat this. Either you can use only zygomatic implant retained prosthesis to close the mucosal defect also, as well as the dentallular defect also. Or you may wish to reconstruct the soft tissue with the surgery also. Then again, you have to decide whether you want to reconstruct the soft tissue first, or you want to place the implant first, or you want to do the both of the things first, like a ZIP flap. And the third option is soft tissue and hard tissue reconstruction, both like the Satyajit sir has shown us with the free fibula flap. And in that also, so you can place implant immediately also, and you can place implant delayed also. So you have to follow you have to make your own protocol according to the demand of the case. In this lecture, we will be mostly concentrated over the zygomatic implant retained prosthesis only, from which we will try to rehabilitate the most of the cases, because even if the cases of it is a palatal perforation or palatal mucosal defect is there, once you give the prosthesis along with the implant, if you feel that there is still nasal regurgitation is there, or patient is not happy with that, then later on again you can go for the free flap and you can close the defect while perforating the implant can come out through that flap. This is the diagram or picture which I have taken from a book by edited by Professor Beinmark himself. And it is a very old book, and these are very old pictures. And you can see that how they used to treat the maxillectomy defects. And these are the sites which they have recommended for the implant placement for the maxillary defects, maxillectomy patients. So it is not the zygomatic implant which is important. We know that if the zygoma bone is there, everybody can place the zygomatic implant. The most important other implants are most important implants, which includes the pterygoid implants, the implant into the lateral nasal wall if it is remaining, and the anterior angulated implant or anterior tapered implant. You can see that at that time also, they were not interested in removing the natural tooth. They wanted to place they placed the implant in the palatal and superior and the palatal bone, either horizontally or obliquely, and sometimes you can take the anchorage from the nasal floor also. So this is following the same technique we have done our cases also. So we can divide our cases into full arch cases and the partial cases. In full arch cases, if you have only zygoma bone, it could be a quad zygoma. In full arch cases, if it is you have pterygoid also, then quad zygoma along with pterygoid. If in pterygoid, if you found a lot of bone, so yeah, apart from putting a smaller implant in pterygoid, you can put a zygoma implant also. That is, I call it as a extended pterygoid or a sphenoid implant. Similarly, in the partial cases, you can place only a zygoma and a pterygoid, or only zygoma and an anterior implant, or it can be a combination of pterygoid, zygoma, and an anterior implant, or it can be a combination of extended pterygoid or sphenoid, zygoma, and the pterygoid implants. So that's how you have to devise your plan. And then prosthesis also you have to devise according to the soft tissue defect. If the soft tissue defect is too big, then you will go for a removable prosthesis over the implant. If the soft tissue defect is small, you feel that you can close it with the fixed prosthesis, then you can go ahead with the fixed prosthesis. So I'll just show you the different type of cases. Then in last, we'll discuss some points that how the treatment of mucormycosis with zygomatic implant is different from the another patient, what we have learned from these patients. So this was a case in which we didn't have pterygoid. So we did it with the quad zygoma and a removable prosthesis, because when we removed his maxilla, after healing, you can see the pterygoids were also removed. So after healing, it was a huge palatal defect, and you can see even the nasal turbinates are visible. So we placed quad zygoma, a bar was given, and a removable denture was given to him. So this is a rehabilitation with a quad zygoma with a removable prosthesis, because it was the palatal defect was too much. Then another case, same, because pterygoids were not there, quad zygoma were used, but because in this case the palatal perforations were smaller, so we could give him a fixed prosthesis. You see, this was after maxillectomy healing. Now quad zygoma was done. So during suturing, we could close the defect. So now only small defects are remaining. So we could give him a fixed metal ceramic prosthesis. If you feel that you want to reline the prosthesis, then instead of metal ceramic prosthesis, you can use a metal acrylic prosthesis also. So this was a metal ceramic prosthesis given on a quad zygoma patient. Then, because if the pterygoids are available, then don't leave them. You should always use the pterygoids also because it will avoid cantilever. And apart from that, it will give you a rescue implant in case, because there are higher chances of failure of zygoma in the Mucor patient. If you lose any 1 or 2 implants of a zygoma implant, the pterygoids will act as a rescue implant for you. So like this case we did with the quad zygoma and pterygoids. Same type of case. So did quad zygoma, pterygoids are not visible here because of the poor reflection. And this is after healing. This is one more important finding I'll just discuss. Can you see these perforations? Anyway, this was a metal acrylic prosthesis. Fixed prosthesis given to him. So this was quad zygoma and pterygoids. You can see the pterygoids, both the pterygoids engaged. Then if you have, because preoperative evaluation is a must, if you have a CBCT, and like Dr. Krishna said, you should always use DTX Pro software. So on DTX, we realized that we have sufficient bone available in the pterygoid region. So I decided to go for a zygomatic implant in the pterygoid region in this case. So it was extended pterygoid sphenoid implant. So again, quad zygoma and a pterygoid implant. This was after healing. And this was a fixed prosthesis given to her. This is the same patient we had in our video. And as sir has explained also that you have to always take care of the anterior posterior spreads of your zygoma implant. It is not only the placement of zygoma, but their spread should be. And of course, if you have a pterygoid, it will avoid the cantilever also. So this was post-loading CBCT, and you can see this was the zygoma implant in the pterygoid region extending into the base of the sphenoid. Coming to the unilateral cases, you can see that either you can use, if you are able to place your zygomatic implant close to the remaining natural tooth, then there is no need to place anterior implant. You can combine with the pterygoid implant if it is pterygoid plates are available. So like this, you can see 2 zygomas and 1 pterygoid implant, and a screw retained prosthesis was given to her. In case pterygoids are not there, then you have to combine your zygomatic implants with the anterior implant. Anterior implant, either you remove the anterior tooth and place an implant there, or you place your anterior implant palatal. If the palatal bone is thick, then you can place your anterior implant palatal to that. In this case, palatal bone was very thin, so we have to remove one lateral incisor, and we have to place a implant, axial implant. But then the advantage of removing the lateral incisor was we got ample amount of room to place the anterior implant. So we could place, you can see that we could place the anterior most implant almost horizontal. I'll show you the pictures. So this was the defect. So you can see this anterior placement of anterior implant was possible only because we have extracted the lateral incisor. And since we had sufficient amount of bone available, we could place 3 zygoma in this case. Otherwise, usually 2 zygomas are enough. I still have a doubt whether 3 zygoma gives any better advantage to us. So you can see that because we removed the lateral incisor, we had sufficient space to place an anterior implant where exactly we wanted. And this was a fixed prosthesis given to her. Then another unilateral case, which was combined with 2 zygomas, anterior tilted implant. So if you don't want to remove the central incisor or the lateral incisor, you have to tilt your implant behind the bone, behind the incisor roots. So this was, you can see the zygoma implant, anterior zygoma was coming quite away from the natural dentition. So there was a big cantilever. So you have to place an anterior implant, and either you extract the lateral incisor or you place it palatal to it. So we preferred placing it palatal to it so that we don't have to extract it. And this was a screw retained prosthesis given to him. So this goes above the roots and palatal to it. I'll show you another picture which will explain this. Then again, double zygoma, anterior tilted implant, and extended pterygoid. So this case was difficult. So we made a guide on DTX Pro for the pterygoid implant itself, and guided we did the pterygoid. Flapless. So first we place the flapless zygoma in the pterygoid region, because usually we look for the pterygoid into slightly on the lateral side. We don't expect pterygoid into this medial side. And lower part of the pterygoid disturbed. So we didn't have the tactile sensation. So we had to opt for the guided surgery. And after that, we raised the flap and placed two zygoma implant and one anterior implant crossing obliquely behind the roots of the incisors. And this was immediately loaded. And now she is under metal trial stage. She is suffering from some problems, so she cannot come for final prosthesis, but this is how it will look like. This was her pterygoid. You can see it is engaging the sphenoid bone. Now just one slide. This is just I want to speak about the anterior implant. You can see this is almost horizontal going above the roots of the central incisor. So this is important because you can see that these are the roots of the central incisor, and above that there is sufficient bone available on the palatal side in which you can place your implant. But always use a conical connection implant in this type of cases. So you can see that this is from central incisor section from central, lateral, and the canine. So the implant is away from the roots. So as such, there is no danger for the vitality of the teeth. And so why I was so confident by treating these patients with the prosthesis only, because fortunately we happened to treat one case 7 years back, same type of case with the same implant support, zygomatic implant supported prosthesis. So this was his pre-op CBCT and this was his post CBCT. This was his defect. We placed same one anterior implant, two zygoma and pterygoids. One metal ceramic prosthesis was given to him. And now it has been 7 years. He has been coming regularly. He never have any complaint. Whenever we opens his prosthesis, we found some crusting over the zygomatic implant because of the deposition of the secretions. Otherwise, he has no problem. There is no infection in the sinus. Nothing is there. So that gives us the confidence that most likely there will be no major problem if we don't close the soft tissue defect with the reconstruction, if we just close it with the prosthesis. What are the different things which we have learned from the in these cases? The most important thing is, if you will see that in the normal case, the zygoma is quite oblique or quite vertical, but in the Mucor cases or in the oncology cases, the zygoma is almost horizontal, especially the anterior zygoma, which is almost horizontal. But so for in these type of cases, you can see that you most of the time, if you have used a 0-degree implant, you will have to use either a 55-degree abutment or a 60-degree abutment. The problem with 60-degree abutment is its opening will come somewhere here. Now, how will you open it post-operatively? Suppose it becomes loose enough, neither you can open it or neither you can tighten it. You have to give an incision here, you have to expose the soft tissue, and then only you can open it. Because at the time of surgery, there was a lot of gap was there. So you could place it and you can tighten it. But once the healing is done, because the 60-degree and 55-degree abutments axis hole is quite superior like this. So I always prefer to use a 45-degree angle zygomatic implant, especially in the anterior region. And you can see it is not only in the post-operative problem, intraoperative also. You can see that when you try to place 60-degree or 45-degree implant, the 55-degree abutment, you can see the hex driver is touching the contralateral mucosa. The insertion tool is touching the contralateral mucosa. Even putting the cover screw was difficult. So it is always advisable when you are placing your implants in a horizontal fashion to use a 45-degree angled implant rather than using a 0-degree implant. Another problem is in our initial cases, we experienced that even after maxillectomy, we never had a dehiscence. It was a good healing. But when we placed the implant, when we used to give the incision at the junction of the buccal mucosa and the palatal mucosa. And post-operatively, we frequently used to found the dehiscence. So now we have, you can see in that case also. So now we have changed the technique. Now we don't give incision at the junction of the buccal mucosa and the palatal mucosa. Now we give incision away from this junction in the buccal mucosa only, so that we can suture it and there will be no dehiscence like this. So this is the junction, and this you can see our incision is away from it. Then we do the drilling through this window, but then we make a tunnel beneath the palatal mucosa, and then our implant comes out through this tunnel. But we don't give incision through at the junction of palatal buccal mucosa. Another problem is because most of the time the palatal mucosa is retracted and you suture your buccal mucosa to that palatal mucosa. So apparently you feel that your implants are coming out at the junction of the buccal and the palatal mucosa. But because the palatal mucosa is quite retracted, your anterior implant are also quite posteriorly. So you feel that intraoperatively, you may feel that they are in the right position, but actually they should have come slightly more anterior to avoid the more buccolingual cantilever. So you can see that these implants should have come slightly more anterior so that this cantilever could be avoided. And then when you place your implant, when you want to place your zygomatic implant, anterior implant, quite anteriorly, you always make a mistake that you turn your handpiece slightly posteriorly so that these implants converge to each other. So always take care your anterior implant should remain parallel to the infraorbital margin. Like this. Then there are little other problems are there. You can see that this was in the final, this picture I have taken the final stage of the prosthesis. I could see this green thing. And when I removed it, it was the elastomeric impression material, which got pushed up while taking the impression. So always put something inside there while taking the impression. Then another important complication is the failure of implants. Like you can see, I placed 5 implants in this patient. And then because we got a very high stability, we immediately started giving the prosthesis. You can see this was in the this was the prosthetic phase, transfer copings are attached. And then in the final stage, when she came for the prosthesis, out of these 3 implants came out while just removing the healing cap. And we had to give her, because it was a Diwali time, we had to give her the final prosthesis on the 2 implants only. Now both of these 2 implants are also moving right now. So now it is very depressing and distressing and disappointing situation, because now we are not sure whether will be able to place more zygomatic implant into her, or whether she will be able to pop up with another surgery or other microvascular surgery. So what we have learned, almost in 4 or 5 cases, we had this type of complication. So after that, we have stopped doing immediate loading. We'll just put the implant, leave it there. If they are beneath the mucosa, then it's fine. If they are exposed in the oral cavity, then we'll splint them with a bar, but we will not load it. We started loading it after 3 months only. And the reason behind what I was thinking, I was searching the literature, so I found that one of the reason may be that this article says that if your zygomatic implant is in less than 10 millimeter of bone, the chances of failure is 3 times higher. And the problem occurs in the mucormycosis cases is, in normal case, we place our zygomatic implant obliquely. So there will be engagement of more bone. In Mucor cases, usually most of the time, because we are going more horizontally, so our implant goes perpendicular to the zygomatic bone. Like in this case, you can see. So most of the time, you will see that it is 7, 8, 9, 10 mm bone only, which it is available. Because if you don't take care, the amount of zygomatic bone which you have engaged is less. Another important thing which I have to remember is it is the bone which is near the orbit, which is the hardest one. So always try to utilize that bone like this. So always place your implant near to and parallel to the infraorbital margin, because that bone is very hard. So at least this implant will survive even if the lower bone is not that much hard. Another change which we have done is now we have avoided exposure of the external surface of the zygoma, because already there is probably there is less of blood supplies there. So while placing the zygoma implant, we usually expose the external surface of the zygoma also, so that we can see the perforation of the drill. But now we have stopped doing it. We just palpate it. We have not done now we don't expose the lateral surface of the zygoma. And third, one more important thing is, as Sir has said, that we have to wait for 6 months. You should always wait for 3 to 6 months, because you never know. We have removed the maxillary part, alveolar part, but zygoma being a thick bone, it may represent it necrosis later on. But then contrary to that, sometimes you can see that like this case, this patient from beginning, she had a necrosis of the zygoma. We just removed her maxilla, and just we can see the amount of healing she had in few months. So her zygoma was totally healed, and now we had placed the implant also to her. She is just waiting for the rehabilitation. So you never know how will your body react or patient's body will react. So you should always wait it. Now, similarly, now it is a big time, or quite a longer time I've spent from the pandemic, from the second wave. So now we are getting cases who has got maxilla necrosed almost 6, 7, 8 months back. So in those cases, you can do the simultaneous, you can remove the necrosed part, and simultaneously you can put the implant in the zygoma. In those cases, there is no need to wait, because already 7, 8 months have been 7, 8 months have gone. If the zygoma had to go under necrosis, it was already necrosed. So there is no necrosis in the zygoma, so you can directly place the implant. So you can see that zygoma can, with the zygoma implants only, you can rehabilitate not only the dentalular part, but the confidence and the quality of life of the patient also. Thank you very much. If you have any questions, you can ask me.
Thank you very much, sir. May I now request our Honorable General Secretary, Dr. Girish Rao, to please give the certificate of appreciation to Dr. Sankalp Mittal. Thank you very much, sir.
I'll help you. As we come to the end of today's morning program, we would be failing in our duty if we don't thank the core organizing committee for tirelessly working towards the success of this program. We would also like to thank our sponsors, the principal sponsors, Lucid Implants and CETAS, AK Surgicals, SK Surgicals, and Medapharma, Avon Logics, who have been tirelessly working with us, and Mrs. Shilpa and Mr. Praveen, who have been the core team to make sure that this event goes live globally. RGUHS for the premises. Special thanks to our newly appointed Vice Chancellor, Dr. M.K. Ramesh sir, and Deputy Registrar, Dr. B. Vasanta Shetty for their support. The audio-visual team, Skyline Productions. The caterers for today's program, the Rangadorai caterers for their amazing masal dosas and crispy vadas today morning, and also Pakashala caterers. We would be failing in our duty if we don't thank our dear Megha Rao, who has been on her toes right from morning. And in fact, she continues to do so even now for the photography. They say, Manzil milegi, batakkar hi sahi, gumrah to wo hain, jo ghar se nikle hi nahi.
We hope that Feb 13th is just a curtain raiser for the roadmap that lies ahead, and we'll pave the way for brighter and happier prospects for the survivors of this unfortunate mucormycosis. They have survived a nasty battle, but we are here to make their lives better, give them hope, restore back dignity in their lives. Oral and maxillofacial surgery gives an opportunity to not just touch lives, but also gives back smiles and happiness. Again, wishing you all a very happy Oral and Maxillofacial Surgeons Day. And do join us for the evening session on safety in surgical practice and the talent show.
We thank the AOMSI head office and our dear guru and mentor, Dr. Girish Rao sir, for giving us this opportunity to host this magnanimous event.
This is Dr. Sri Gauri.
And Dr. Sai Swaroop signing off. Thank you.
Thank you very much.